Good afternoon, everyone. And on behalf of Director General, Indian Council of Medical Research, I welcome all the participants who have joined today to the webinar, which is being conducted by Indian Council of Medical Research. The purpose of conducting this webinar is to make the participants and the physicians aware about the standard treatment workflows which have been developed by ICMR in collaboration with National Health Authority, Ministry of Health and Family Welfare, and WHO India Country Representative Office. The purpose of developing standard treatment workflow, I will take a few minutes to tell about it, that these have been developed as a part of, to cut down the long, lengthy guidelines which are developed for different conditions, different indoor and outdoor conditions to manage the patients of different categories. So it was, it is usually found quite difficult to go through those lengthy guidelines. So the efforts were made by ICMR in collaboration with Ministry of Health and Family Welfare that there should be some simple, small app-based provision, and the simplified approach of these guidelines can be made available for the physicians who are treating these conditions. So efforts were done to make it as a one-pager document for various conditions. So far we have developed 122 standard treatment workflows in 23 specialties. These are already available on the website, ICMR website, and they are downloadable on the mobile app from the Google Play Store, either in the form of on the Android phones as well as on the iPhones. So on the different specialties, we are beginning this first webinar to make the physicians aware about that, how these were prepared and what are the key features of the standard treatment workflows. And we're beginning with the specialty, which is dermatology. To briefly tell about dermatology, we have there are various conditions patients approach to the outdoor patient clinic for various diseases like psoriasis, for alopecia, for some eczema, for urticaria. So these are some of the common conditions. So the conditions on which the standard treatment workflows have to be prepared primarily are based upon the common conditions to begin with. And if they need some further discussion, so that things are also being discussed. So while discussing preparing the standard treatment workflow, the things are taken into account, that what are the chief complaints of those conditions, how do they report with it, and what can be done at various levels of facility of care in the primary, secondary, or tertiary level. The efforts are made while developing the standard treatment workflow that at least we don't put up such kind of investigations which are high-end investigations, which are not required for making that diagnosis, but they are mandatory. Those are put up into the categories like essential investigations, the desirable, as well as the optional investigation. Same is the management point of view. So the efforts have been done and the care has been taken to put up at various levels of care. If those facilities are available at a PHC, CHC, or district level hospitals, the physicians can manage that, or else they can refer it to the higher facilities. So in nutshell, that the standard treatment workflow are the one-pager document. They are downloadable from the ICMR website and from the mobile applications as well. And to begin with, I thank all the participants who have joined today. And the audience for this standard treatment workflow, primarily we have kept it for the physicians at various levels of care in the public healthcare system as well as at the private healthcare system as well. Though the approach has been taken care into account that the faculty and the postgraduate students and undergraduate students in the medical colleges in public and private healthcare facilities are also to be benefited. And efforts are going on to introduce into as a part of the training program at the UGs and the PGs level as well. Today we have the guest from the discipline of the dermatology. We have Professor Khaitan from All India Institute of Medical Sciences, New Delhi, who have been part of the committee. And then we have Dr. Deepika Pandhi from University College of Medical Sciences, Dilshad Garden, New Delhi. Along with us, I have one more expert guest with me, Dr. Sudha Chandrasekhar, who has been working with us in very close association with National Health Authority, Ministry of Health and Family Welfare. Before we really begin with the dermatology part of the STWs, I will request Dr. Sudha to just apprise the members that how are we taken into account of the STWs for its packages. Thank you all.
Thanks, everyone. It's very important that, we are in a stage where we are going all out to disseminate. I think we have been working very closely for the past couple of years, making sure that the ICMR, which has set up the STW committees in every specialty, we have co-opted with the National Health Authority, both in the development of packages and also the guidelines. And we have integrated in most of the cases, especially because our PMJY scheme caters to hospitalization. So the STGs of various other specialties we have integrated within our IT system and disseminated to the states and also to the physicians with empaneled in our hospitals. But dermatology is one where we are looking at how do we, expand the specialty, because we have very limited packages, because most of the care is given in the outpatient sector. So that is something we would definitely need your valuable inputs on some of the conditions which we can cover, and then also develop specific guidelines for those. Apart from the common conditions that we have started with, we need to expand this effort to include as many conditions as possible. And for that, I think a collaborative effort from everyone concerned would be very useful. And the most important is to adhere to the guidelines. I think as treating physicians, the newer postgraduates and specialists are coming out of these various medical colleges, I think that was one of the reasons that we are looking at disseminating in a very wide way, so that these people are trained from the beginning. And also there is a consensus among the experts who are already there to ensure that we all follow a certain set of standard protocols, though there might be deviations because of some patient-related conditions. But at least in 90 to 95% of the cases, the management of the patients are standardized for each of these conditions. So this, for us, it mainly helps in improving the pre-authorization and claim settlement, especially for various packages. And also for the hospitals, it means that it is a faster reimbursement to the for the packages that they have booked. So in that sense, it's a win-win situation for everybody. And we are very pleased to continue the collaboration with ICMR. And thanks, Dr. Ashu, for inviting me to be a part of this seminar.
Thank you so much, ma'am. Now we move on to the specialty experts, Professor Khaitan, to have deliberations about that how these specialty was chosen and how these STWs were developed for the benefit of the physicians at large. Professor Khaitan.
Good afternoon, friends. I can see some of the very senior people in the audience, and obviously I do not know everyone. Can you hear me, Chair? Anybody from the audience, please respond if you are hearing me, if you are able to listen to us. Anybody say yes?
Yes. Thank you.
Right. So we started this task. I'll give you in 1 minute overview that ICMR chose many specialties. For dermatology, the challenge was to choose topics, because if we are going to choose common conditions which can be taken care at primary level or secondary level. Tertiary level, we were not that much bothered, but then we have also, the flow goes up to tertiary level. So the first challenge was how many conditions to choose. They had limit of about 10. We chose 13 conditions because the one purpose is all of us are primarily MBBS background, and all specialties we do study at MBBS level. So primary purpose was to orient and reorient, because at various level of practice, years and decades, we may lose touch with many specialties. Particularly general physicians, they have to cater to all specialties in a way. So that was one purpose, that at least some common conditions can be, we can make a standard treatment workflow. And the purpose of that was that immediate care, what should be given, and specific care, if the diagnosis is made based on primarily clinical situation, maybe with some investigations, then the specific care can also be given. More than that, if there is a doubt when to refer, because referral to higher center, whether it is secondary care or tertiary care, is also an important task by all physicians. And if there is a red flag sign, we have put in almost all conditions where the urgency of intervention is important. So if there is a red flag sign, then if one can refer to a specialist or a higher center, secondary care center or tertiary care. So that is also important. Now, we cannot cover all topics in today's webinar, but I can show that it is, if you can see, you can go to the site. It is very friendly app. Dr. Ashu has already explained to that. And we will share that. You can go at the ICMR site and write STW, you will get the link and app. Now, I will just to give you the feel. See, I'm covering one topic which we covered into 2 pages. Usually we have covered in 1 page. That is cutaneous adverse drug reactions. Why we are starting with this? Some interruption. Just hold on, please.
Going to share the screen.
Yeah, so we are sharing the screen. You can see the QR code or so it's not difficult. If you go to ICMR site, you go to STW, and then you can both Android as well as the App Store, you can find the QR code and then you can download and see. So this is handy at all levels, primary level, secondary level, and of course tertiary level. So coming back to the topic, which I'm cutaneous, now is it okay on the screen? Yeah, this side. So why we chose first topic as cutaneous adverse drug reaction? Because this is one area where perhaps the commonality is very, very important. Somebody who is treating a patient with, say, pulmonary tuberculosis, a physician is treating with ATT, or a neurological disease, seizure disorder, one is treating with anti-epileptic, or for that matter, any drug. The cutaneous adverse drug reactions are common, but there is one important thing about this, that if you label a person that a patient is allergic to drug A or B, that label remains lifelong. So that loose label without evidence should not be put. And if it is there, then we must also warn that such drug cannot be taken in the future. Such drug means that particular drug and a related, chemically related agent. For that matter, say for example, if somebody is allergic to, say, ciprofloxacin, so other quinolones also become risky, but not necessarily it will happen in all. So this is a basic thing which we have to understand. Now, why, again, I'm emphasizing one more important thing. Suppose somebody is receiving ATT and receiving 4 drugs, and there is cutaneous adverse drug reaction. Not necessarily all 4 drugs will be responsible. And obviously, you have to give ATT. This is one condition where you have to continue treatment. So how to go about in a patient of adverse reaction, that how to stop, when to stop, and then how to restart. So all these steps are being given in this standard treatment work. For practical purposes, we have divided into common types of ADR and in common, non-severe and severe. So suppose we take example of fixed drug eruption. Fixed drug eruption is a condition where any molecule which is being given, and if there is a reaction, that means there will be a circumscribed lesion. There may be 1 or 2 or 3, not many usually. And whenever there is a repeat exposure to that drug, the reaction will happen on those areas. Those areas are usually small. So fixed drug eruption it's not a serious situation. So when do you decide that temporal relation with a drug? If you go to the 3rd column of timeline for drug reaction and some typical examples. So if it is within minutes, that means either it is urticaria or angioedema or anaphylaxis. So the drug has been instituted, and then within minutes, if something is happening, that means it is one of the three. But if it is taking few hours, sometimes angioedema may take little longer, but otherwise it happens in minutes. Only fixed drug eruption may recur within few hours, usually within 24 hours. But the most important and common drug reaction, which is maculopapular drug eruption, it happens within few hours, usually within 1 to 3 weeks, or few hours to 2 to 3 weeks. So it is temporal relation which make you suspect that a drug may be having an adverse reaction. Now, this is a kind of hypersensitivity which will require some time, prior exposure, the person is sensitized, and then the next exposure, the person will be showing the drug rash. Now, it is important, those drugs which are given for longer period. So again, I'll give example of ATT, anti-epileptics. So the sensitization is happening. Every day the patient is taking the medication, and within 2 to 3 weeks, first time, the drug reaction will happen. So this timeline one should know at primary level. This one simple history of duration of the drug exposure. Now the question is, somebody taking drug, say for 3 or 4 years, so somebody may be taking antihypertensive for a long time or anti-diabetic for a long time. It is less likely that those drugs which are already there in the system for more than 3 weeks are likely to cause hypersensitivity. Rarely it may happen, but for all practical purposes, that is less likely. So important, coming back to the general principles. Now, in general principles, we have already mentioned that withdrawal of drug is important, but you cannot withdraw a life-saving drug, or you cannot withdraw an essential drug for a long period. So in that case, initially all drugs are suspect, whether the person is taking antipyretic along with, or an analgesic, or antitubercular 3 or 4 drugs, or whatever. So withdrawal of drug is very important. If that one step is taken at primary level, at least further deterioration will reduce unless the half-life of the drug, say for example, phenytoin has a longer. So may the severity may be kind of curtailed. So, and the recognition of danger signs. If there is mucosal involvement, that means lips, oral cavity, eyes, genital mucosa, that means the patient is having a severe type of drug reaction, whether it is in maculopapular drug eruption or Stevens-Johnson or toxic epidermal necrosis. So it is very important that in just one clinical examination, history of duration, and you have to record all the drugs the person is taking. In Indian situation, in our situation, many a time the chemist is giving drug or a physician is giving drug, but the prescription is not brought by the patient. Those difficulty we have to cross, but we have to find the drugs which is being taken by patient at least in last 3 weeks or so. Now, then the systemic symptoms. If the person is having, along with hepatitis or jaundice, high-grade fever and decreased urinary output, that means these are serious situations, and we have to further investigate and decide what specific type of drug reaction is happening, and one should accordingly address that. Now, I will come straight away to say, just for an example of how we have divided at primary care and secondary care. Now, if you come to maculopapular xanthomatous reaction, then at primary care, we have written 4 points, that is withdrawal of the suspected drugs, giving antihistamines. All of us use antihistamine as if all drug reactions can be controlled. No, all reactions cannot be controlled, but there is no harm in giving antihistamine. And at primary level, whether corticosteroid has to be given or not, we thought that it should be given at secondary level only. But if it is toxic epidermal necrolysis or Stevens-Johnson, then one may start as early as possible and then refer to a higher center. But at secondary level, it is very important. Confirm the diagnosis by history and clinical findings. Admit if red flag signs are present. Admission are for 2 purposes: to look for systemic involvement and the evolution of drug reaction. A drug reaction may become static after some time, maybe few hours, but if it is deteriorating further, that means you have to be more aggressive in treatment. And here I will mention the red flag signs also. So the red flag signs, as I have mentioned, mucosal involvement and in cutaneous involvement if the lesions are purpuric. Just by palpating the red lesions, if the blanchability is there, they are unlikely to be purpuric, and if the blanchability is not there, then it's more likely to be purpuric. Then bullous lesion. Blistering is a severe change, whether it is because of irritation or whether it is because of allergic phenomenon or whether it is because of keratinocyte damage. So bullous lesion. And then skin tenderness. This is very important. We should not miss. If there is tenderness, we are going into the realm of toxic epidermal necrolysis, because this is an important sign of toxic epidermal necrolysis. The erythroderma, if the maculopapular eruption continues for some days, then obviously the drug is being given and sensitivity is going on. So the patient who may develop just mild macular rash or papular rash may throw erythroderma, that means the entire skin will be involved. So this is also a red flag sign. And of course, high-grade fever, jaundice, renal involvement, and significant eosinophilia. So if the eosinophilia, so one important point I want to communicate with our physician friends, that just presence of eosinophilia does not mean the patient is having drug reaction. But if eosinophilia is increasing along with systemic symptoms and severe drug reaction, that means we are going into the DRESS, that is drug rash with eosinophilia with systemic symptoms. So if you go through this STW, you will realize that one has to only recognize 4 or 5 things. At upper secondary care, one can manage that. And of course, there will be some cases where more specialized tertiary care will be required. Now, one point about drug provocation. I'm not covering all the points and I'm not reading out all the points. But if you see drug provocation, why it becomes crucial? Suppose somebody is receiving ATT. It's a practical situation. 4 drugs you have to stop initially, but you also have to give antitubercular therapy. So out of 4, which is the suspect? So once the drug reaction is controlled, then it should be reinstituted one by one. All the 4 drugs should not be restarted simultaneously. Then again, suppose there is reaction, you will not know which is the suspect. So to identify the suspect drug, one has to reinstitute one by one. And if you are more careful, then maybe initially on day 1, you give half the therapeutic dose or 1/4 of therapeutic dose. And next day you again give 1/4 or half. And third day you give full. So if that goes safe, that means out of 4 drugs, 1 drug has been found to be safe. Then you add second. Now, which one to introduce first and which one to introduce second will also depend on the prevalence of in the literature. Some drugs are notorious, some drugs are causing more drug reaction. Then you can go by that, or depending on which drug is required, definitely required, then you can start with that also. So this is about drug provocation, but you have to be careful. The drug provocation should not be done at home. It has to be done under supervision. That means the patient has to be under care indoor. So, and because there can be issues if there is, and then drug provocation should not be done in all patients if the suspect drug is very obvious. Secondly, if the mucosal features are present, suppose eye involvement is there, then one has to be really extra careful whether to undertake drug provocation or not. All these points we have covered. These are all practical therapeutic points rather than theory of drug reaction. Theory of drug reaction you will find in textbooks. So coming back to non-severe fixed drug eruption, maculopapular can be severe sometimes, but initially non-severe, and then the severe. Can we go to the page 2, part B? This is the first webinar, so there are some hiccups. Please bear with us. So, it is going to open. So, in the meantime, I can tell you that one should be at least aware of 2 very severe, sometimes life-threatening adverse cutaneous drug reaction. That is Stevens-Johnson syndrome, and toxic epidermal necrolysis. Yes, no, not this. इसका फोटो पे ले आइए। शेयर है नहीं, इसके फोटो पे ले आइए। फोटो पे नीचे थोड़ा ले आइए, थोड़ा और। अभी शेयर नहीं, just hold on. So if you, for example, if you take look at these three pictures, so the toxic epidermal necrolysis in the first one, if you see, if you start with, there are frank erythematous bilateral symmetrical multiple lesions which are non-blanchable, and if you start peeling, they will start, I mean, the separation will be very easy. There can be sheets of separation, and since the separation happens, so the chances of barrier function loss and secondary pyogenic infection becomes higher. So these are examples of toxic epidermal necrolysis, and mucosal involvement is much more common both in toxic epidermal necrolysis and SJs. So these are important, where stoppage of drug immediately is important. Institution of, to start with, corticosteroid is important. Cyclosporine also works in this, and IVIG is sometimes required. Those situations are already described when we have written the treatment, because here we have written little detailed treatment because these are serious. Sometimes there can be life-threatening also. So just one thing which I will read about secondary level care, because it is important. There will be loss of fluid and electrolyte imbalance, so it is important to replace fluid. Then vitals have to be assessed. The local care, one should not be very aggressive. It is not like a surgical debridement of peeling of the peeled skin. It is basically to maintain the quality of bed, that further peeling does not happen, and maybe a gentle cover with Vaseline gauze is enough. Maybe sometime with topical antibacterial agents like mifepristone. So eye care is again important. One has to take a consultation of an ophthalmological colleague, because if there is mucosal involvement, that means cornea is damaged or cornea is getting affected, then it is very important to take care of that to prevent blindness. So it is not only life-threatening, it is also organ-threatening. So that is important. Then systemic therapy, the role of corticosteroid, by and large, if you start early, adequate dose of systemic corticosteroid, and then you start tapering rather fast, that means within 48 to 72 hours, you achieve the control, and then you start tapering within a week. That will not harm. There are a lot of controversies about use of systemic corticosteroid, but then they are wonder drugs if they are used at appropriate time in adequate dose and not used for a long term. And if there is secondary infection, that can be, if that is taken care, then the difficulty is not with systemic corticosteroid. Cyclosporine is also an important drug in these two conditions, SJS and TEA. And if more than 30% body surface area is involved, then like burn, you have to maintain a barrier nursing and ICU setup and more frequent kind of monitoring. So I have covered, just to give you an overview. I'm not covering each and every point in today's webinar. Why I have covered adverse cutaneous drug reaction, because whichever specialty you are working in or whatever cases you are getting, there will be some drug reaction. So again, just to conclude and to re-emphasize 2 points, don't say that a person is allergic to many drugs. Usually the person is allergic to one drug or maximum 2 drugs, very, very rarely more than 2 drugs. A person may be receiving so many drugs. So one has to identify, stop the suspected drug, or if possible, all the drugs to start with, and manage fast. And if there is a doubt, refer to a specialist. Thank you very much. And we will need your feedback. I think ICMR पे वो लिख सकते हैं, mail सकते हैं. Mail, so you please mail if there is, so once you go through STW and if there is any suggestion, you can mail to us.
You can tell the topics on which we have prepared. All the topics are there on the screen.
Okay, so in dermatology, we have covered acne, alopecia, bacterial skin infection, then cutaneous drug reaction, dermatophytosis, which is very, very common, the so-called tinea or fungal infection, various types of eczema and dermatitis, immunobullous dermatosis like pemphigus, etc. Psoriasis, a common drug. We have also covered one important topic, that is rational use of topical corticosteroid. We find there is a lot of misuse and abuse of topical corticosteroid by various people, including physicians, chemists. So we want to sensitize our fraternity, the medical fraternity, how to rationally use topical corticosteroid. And of course, common conditions like scabies, urticaria, varicella, herpes, and vitiligo. Now I hand over to Dr. Professor Deepika Pandhi to cover some more topics.
Thank you, sir. So,
Yeah,
firstly,
if
you could stop. Thank you. So, firstly, we would like to really thank Dr. Ashu and ICMR for beginning with dermatology. That is something which we really appreciate, because dermatology for the first time is being given this much, credit. So, because why we are talking about this is that, dermatological diseases or skin diseases are in the top 10 of non-fatal disease burden. This has been reported by WHO. And in India, it said that 6.3 to 11% of the population has skin diseases. And at the primary health center, where we are most concerned, 25 to 35 attendance is due to skin diseases. And we know that what is our ratio, but the ratio of a dermatologist in the general population is 1:1.3 lakhs. And we know most of our population, almost 1 crore, is in the villages. And 10% of dermatologists, it is said, are in the villages. So this further compromises their access to trained consultation. As most primary care physicians we know have had very limited, we are all aware, and in MBBS, the constraints of dermatology teaching and how much importance it is given in an MBBS training session, leading to a compromised diagnosis and inappropriate therapy, which is, is not cost effective and increases antimicrobial resistance and adverse effects. So therefore, to ensure universal health coverage, which is our main aim, as Dr. Ashu mentioned, it is imperative to enable at the grassroots level, the primary care physician to make an accurate and prompt diagnosis, be able to initiate treatment, and thereby improve the overall outcome and reduce the cost of illness, thereby fulfilling the goals of the universal health coverage. And I would also like to just mention, like Dr. Khaitan said to Dr. Sudha Chandrasekhar, that we really hope, because even in these existing STWs, we have mentioned where admission is required and where inpatient care is required. So we hope to have at least 3 STWs like CADR, which are covered, immunobullous and severe infections mentioned, and we hope some coverage, insurance coverage will be provided for such patients, which will really go a long way in making the therapy of skin diseases cost effective. So this is just to like a little bit about the overview. So this was a very interesting study from Kashmir. So the cases are in the community camps and the controls are from the tertiary care center in Srinagar. So if you see, the skin infections are mainly there in the camps, therefore significantly more in the camps, but the burden is there and also. This is a failure that even the infections are coming to the tertiary care center. This realizes that optimum tertiary care is not being utilized, because the burden is also being shared at the tertiary care level, emphasizing the need for strengthening of the primary healthcare level. Of course, for non-infectious, you can see that it was more in the tertiary care level.
This was another study done at PGI Chandigarh. So here it is very interesting that the diagnostic concordance with the primary care physician and the teledermatologist was 56%. That means nearly 50% wrong diagnosis and inappropriate therapy. And it was paradoxically very high in dermatophyte and scabies because they overdiagnosed dermatophytes and scabies. It was seen that they were able to diagnose in 85% only 10 disorders because they were not aware of other differential diagnoses, thereby highlighting the need to apprise them about the other close differential diagnoses or even common disorders like dermatophytosis and scabies. Now, this was another interesting thing that was done, I think, in Vadodara, where they reached to the primary care physician and they asked them a structured questionnaire and they showed them what is known as a photo quiz, 10 questions. And it is, a little concern that the mean score was 4 out of 10. And almost 85% of them did not score 50%. So that indicates their knowledge of dermatology, simple disorders presenting to them. Then simple questions like after scabies, I think this is a typical MBBS exam question. After treatment of scabies, when do you expect relief? So majority said in 2 to 3 days. So thereby, they will increase over treatment. We see people applying permethrin again and again and coming with adverse effects. Then even like sir mentioned, the epidemic of tinea. So they said that it's only topical steroids that is responsible. While topical steroid, that means we have succeeded in conveying the harm of topical steroid, but they are not taking into cognizance other factors that might increase. So this was very interesting that this is what is required, which is known as a system analysis. What do they feel are the difficulties and the challenges? Very truthfully, 75% said that they are average or below average. They cannot diagnose skin disorders. There was a great deal of honesty. Then what they said is, we find difficulty in diagnosing, so we refer. 3/4 of them said we refer cases. We cannot diagnose. The other said, which is very worrying, that we use what is known as cocktail therapy. Give everything, quadriderm and everything, combination, antibacterial, which is what leads to complications of dermatosis, this approach, or they Google. So Google is as bad as any, what we call Google doctor, the patients themselves going doing it. And they very, they provided good feedback. What they felt was, what Dr. Ash will be happy to see, is that they needed some guidelines and some training. And so the guidelines, they said, will help them in managing dermatology patients. And this was true, especially for long-term or chronic cases. They said we need training. We do not know how to manage them. And they also requested that we need drugs and lab facility available. So this is a paradox. There is overemphasis on lab facility. The paradox is that when you cannot diagnose, how will the lab help you? You need to be able to diagnose to be able to choose the correct investigations. So this I want to project just as a beginner because this is the first webinar. This is one of our biggest success stories. 30 years of using, NACO, using STI syndromic management. We have learned the pros, we've learned the cons. We've learned the importance of continuous monitoring, feedback, validation, revision, and most importantly, this has been a success due to multidisciplinary interaction, and that is the way forward for all STWs. If we need this to be a success in India, we need to emphasize the importance of all these things that we learned from syndromic management. Though we all know that it is not an unqualified success, there are several concerns. But it has still been able to, keep HIV and STIs to a semblance of control. So this has already been told, the process of development of STWs. But what I like to add to what Dr. Ashu said is that this went through, it has been sort of a process of many years. So it has gone several rounds of revision, re-revision, edits, multiple edits, which they have been very patient to go along with us, and then validation by experts outside the specialty, other subject experts, 2 rounds of that, and then the editorial. So a lot of effort has been put in-house. But of course, like Dr. Khaitan mentioned, we would request feedback because when we actually use it, then we will come to know how well the translatability is, how much is the, if the statements are ambiguous or if there is clarity. So these were the 14. One thing in addition to what has already been said, in dermatology, we felt very passionately about using clinical images for clarity, because there was a general consensus with all the committee members that without clinical images in dermatology, it will not convey any meaning. So that is why the dermatology STW has clinical images. And in addition to where indoor outpatient, as you've already seen, stratified approach, and very importantly, red flag signs. So this is the first one I'll be talking, was like we saw that the infectious are still very common in the primary health center, and still being, as a matter of concern, not being correctly diagnosed. Like we saw for scabies, it was diagnosed double of what it was actually the burden, as well as dermatophytosis. So again, like we tried to keep it very simple, though it looks busy, but it's because it's a single page, and each sentence actually has been put with a lot of thought, and with the reason being that we wanted an important message to go. So we've talked about scabies, where we talk about how usually the symptoms start later. So that is the first message that you get in the first column here, and that you may have outbreaks in schools and orphanages. Then the symptoms and signs, which we have been taught in MBBS, but emphasizing or re-emphasizing that burrows, which are supposed to be the classical sign, may not be seen. They should be looked up in the web spaces and wrist, and vesicles may also be seen. And also importantly, do not miss scabies of the clean. That is, lesions may not be very visible or obvious in people with good hygiene. Then other presentations like nodular scabies over the genitalia, the association with secondary bacterial infection, and crusted scabies, which, though not being common, but we wanted people to remember that there is an entity known as crusted scabies. Like I said, we try to provide images to make sure that the mental picture is very clear. The diagnosis, we stress that it is usually clinical, but if you have access, because remember this is also for secondary and tertiary, you may demonstrate it by a KOH or by dermoscopy, the mite or the Skybella. Then the general measures, which are very important. Now, this is very interesting. We see in our MBBS, no matter how many times we kind of emphasize this to our MBBS students, requires repeat, validation, because they kind of miss out some of the points. Why all members must be treated, why the clothes should be treated, and we've even gone to say people may not be doing it, that keep it in a sealed plastic bag if it's for shoes and other non-washable items. So it's like sir said, providing literal, very, very practical inputs for them. And for how long, 3 days, towels and other bed linen. Then permethrin, the method of application, special attention to what all spaces should be done, how many are 30 grams for an adult and 15 grams for children under 5. So very specific instructions, and to be repeated after 7 to 14 days, not daily, because that is again sometimes a very common error. Then oral treatment, we wanted to emphasize that do not just, because sometimes MBBS people come to know about ivermectin, they tend to, over prescribe it because it's simpler. So what are the indications? Poor compliance or no response to topical? What is the dose? When it should not be given? Avoid in infants, children less than 5 or less than 15 kgs and in pregnancy. Then treatment of secondary infection, where we can refer to the bacterial skin STW, and treatment of crusted scabies, very specific ivermectin in case you come across. Even you do not need to refer anywhere, even if at a secondary and tertiary level. Like Dr. Ashu said, it can be a ready reckoner even for the undergraduates and the postgraduate. That is the idea, a very short synopsis of all the important points at one place. What to do with nodular lesions and post-treatment advice. Now, this is very important, like we saw in that community, study from Vadodara, that itching will not disappear. So you do not expect a magic in 2-3 days. However, if the itching persists for more than 3 to 4 weeks, or if it is spreading or new lesions are noted, then a retreatment and ensuring that the family is treated is warranted. The tagline is very important, because we have put a tagline in all STWs just to tell what is the take-home message, very strong, that we want to give, is that they treat the entire skin and not lesion, because most people, including some, have the concept that you just need to apply on the treatment. on the lesions and not on the whole body. Scabies is different. We want to emphasize, treat the entire body and treat the family and contacts, not the patient alone. Each of these STWs, like the doctor, has a disclaimer. So please remember to, also share this with the patient. So this we have dermatophytosis. We are seeing an epidemic, as Dr. Binod mentioned. So that was the obvious reason why we needed to have an STW on dermatophytosis. So here we want to put this right at the top, that do not self-medicate. This can make the infection more difficult to treat, and do not use any steroid containing over-the-counter cream from their chemist also. This is why it is right on the top, and this is why what we hope every physician would emphasize to their patient on the first contact with the patient itself. So we have a description of the tinea corporis and crurus. We also want to say that diagnosis, KOH, even if you do not have any access, do not hesitate to treat. It's only for doubtful cases or modified cases that you need confirmation for by KOH for the diagnosis. And culture and other advanced methods are not required in routine practice. We also put a simple do's and don'ts, which should be easy to convey to the patients. That is, take a daily bath with regular soap, no antibacterial soaps, dry skin well, wash clothes separately and dry inside out. Do not share your towels and clothes, and do not re-wear clothes without washing. So the usual common mistakes that people make. A topical treatment for limited. We've also emphasized when we need to refer to a specialist or tertiary care, because we've now seen, as all our dermatology colleagues in the audience will agree, that we are seeing people with 2 years, 3 years, 4 years of dermatophyte, which we never saw earlier. And that is because they are being mismanaged at all levels. And it is very important to know when a primary health center or a non-specialist should refer to the tertiary care center or to a dermatology specialist. So extensive disease, where there's minimal improvement after 4 weeks, cure is not achieved, multiple recurrent lesions or persistent lesions, for comorbid conditions where oral therapy may not be permissible, pregnancy, history of prolonged topical steroid or parenteral steroid use. And also it's important to remember that we are seeing a lot of modified lesions which are misdiagnosed and which may be responsible for the misdiagnosis in the study we have discussed earlier, because the topical corticosteroids reduce the inflammation and the ring may be incomplete. The classic ring that we've been taught in UG may not be seen. So also pediatric infection we have provided, tinea pedis and manum. Again, similarly, we provided the general measures, how to ensure that you do not have recurrent and persistent lesion. We've given the oral therapy, what are the options with the doses, and what to do in case of pregnancy. At the tertiary care level, also for sake of completion, we have given that this is the only place where if the patient has been persistent, recurrent, and has chronic dermatophytosis, where you may individualize treatment and start therapy following antifungal susceptibility testing if it is available at this level. And we've also cap itraconazole, we felt should be more appropriate here. So here the tagline says, ensure treatment for adequate duration. So we want to emphasize that it is the duration rather than the drug, because most people do what is known as ping pong with the drug. They keep changing it when they don't respond. They do not wait, or they're not patient with the duration. That is what we wanted to ensure. Then we've also, for sake of completion, talked about onychomycosis, because as you see in the red flare, it says why is it important to treat nail infections, as it is a potential focus for spread. So this is something we would specifically request our physician friends to also pay attention, because it's the diabetics and people with signs of PVD, peripheral vascular diseases, which are more prone, and we see a lot of onychomycosis in these patients. Also, we have, giving patients realistic expectations important. So we specifically put this point that it may not magically disappear. You need to be patient because the nail growth is slow. So they need to understand the pathophysiology, that it will take a few months for a normal nail to appear. And sometimes if it is so disfigured, a normal nail will not come, but the advantage is that you will at least get rid of the infection and it will not spread. So the treatment is also mentioned. The last, we will be talking about bacterial infection. Now, this is one of the busiest, as we know, cutaneous infections are so important. So we talk about the general principles, what to do, how to maintain hygiene, why you have recurrent lesions, look for nasal carriage, atopy, or underlying scabies that may be associated. This is an important message, especially for our medicine friends and pediatricians, and for immunocompromised and diabetic. Then again, the pictorial representation to make it easy. Also, we have a lot of antibiotic abuse. I'm sure ICMR is also now focusing on antimicrobial resistance prevention. So all do not require oral antibiotics. So emphasize where to use oral antibiotics for extensive involvement, numerous lesions, lymphadenopathy, or in outbreaks to prevent transmission. Similarly, simple message for ecthyma. This requires oral antibiotics. That clarity is there where you should not defer antibiotics and where you should, that should be your first line of therapy. Folliculitis, again, topical antibiotics if where it is limited, and oral antibiotics for multiple lesions. And what to do in recurrent folliculitis. So screen family and screen for nasal staph carriage. This is a simple thing which, if taken, will really reduce the morbidity and the duration of illness. Similarly, we are all familiar in surgery, especially when we get a lot of carbuncle, abscess, furunculosis. Simply, it is describing what to do if it is limited furunculosis, carbuncle, what is the management with the pictorial, and abscess, what is the management. Again, cellulitis and erysipelas with division into mild, moderate, severe. And we've also tried to tell what is mild cellulitis, what is moderate. And from moderate onward, we have stressed on hospitalization and parenteral antibiotics. Then also that investigations are not required for all. Where to do investigations, what are the complications? And like we've been saying again, the red flag signs, whether temperature is more than 100, WBC is more increased, or it is decreased, both of them, the heart rate, severe pain followed by deceptive absence where the patient has progressed to necrotizing fasciitis or dark discoloration of the overlying skin. Staphylococcal scalded syndrome, again, we wanted to emphasize, which is a common error by some of the physicians, that bacteria cannot be demonstrated from the blister. It may be demonstrated in the primary lesion, but not from the blister of staphylococcal scalded skin syndrome, and a sterile culture does not rule out the diagnosis. So this is the pharmacotherapy. So antibiotics for skin and soft tissue infection, and naturally this would need to be adapted to your local profile where you're doing your antibiotic surveillance. And so then you have the beta-lactams, and if allergic to penicillin, that has been provided. For nasal carriage, treatment by 2% mupirocin. If when to suspect the need for MRSA, we know even the community MRSA prevalence is increasing. If there is poor immune status, severe systemic signs, MRSA infection documented elsewhere, and if no improvement after 48 to 72 hours of penetrating trauma. So there the options have been given. So the take-home message which we hope is that these STWs will aid physicians at all levels, including the primary care physicians, to augment the dermatological services which are sadly lacking, especially in the rural areas and even in the urban areas, if I may add, by management of common dermatological conditions, thereby reducing the burden on tertiary care centers, which is the aim if this is implemented well. And this will require a lot of training of all physicians, because for them to be able to use these STWs, inappropriate management of poorly trained first contact healthcare worker is increasing the burden on all specialists. So we are talking about dermatology, on dermatologists for treating complications by irrational therapy and severe dermatosis due to negligence. So there is an urgent need for training. Appropriate timely treatment, as we all know, will reduce the morbidity, mortality, and reduce the cost of illness, which is the aim, because Ayushman Bharat, there are 3 prongs, I think, that minimum standard of care, then it should be easily accessible, and it should be cost effective. So we have had internal and external validation, like we mentioned, but there is need for validation in actual healthcare setting. And we hope to modify based on feedback received from the field and increase we also hope with the consent and with the support of ICMR to increase the number of conditions covered, and also to provide links for more pictures, more the pharmacotherapy, the tables and suggested reading and references with more details. So I would like to place on record our appreciation for all our committee members, Dr. Ananta Khurana from RML, Dr. Deepankar Dey and Dr. Rahul Mahajan from PGI Chandigarh, Dr. Renu George, who was then in CMC Vellore, and Dr. Vishal Gupta from All India Institute of Medical Sciences, Delhi. So it's also available on Twitter. We have hardbound copies, which will be hopefully Dr. Ashu gets shared with the primary care centers with stickable posters. I don't know if you can see, it's there on the wall here. And somebody asked for the link in chat. So these are the two links, if you can note it. And otherwise, it's available, like Dr. Ashu mentioned, on the ICMR site and mobile applications compatible both with Android and with iOS platform. Thank you.
Participants, do you have any question? So you may raise your hand, then we will.
There are some questions in the chat.
Chat का तो मैंने एक है, मैंने reply कर दिया. Also these generic questions where we can say.
So one of the suggestions is what we are saying in the conclusion. They want more conditions to be added. He's suggesting that lichen planus and molluscum can also be added. So we do have psoriasis, but that's well taken. Lichen planus is also fairly common.
And raise की है, उनको allow करो. मैं एक बार आपने कुछ
ऐसे allow कर दिया
सभी को कर
So thank you, everyone. Is there any queries regarding dermatology, STWs, or standard treatment workflows in general also? Because this is the first webinar, and this is the first mode of communication to reaching to all the physicians. I think I can see, people from the state health department, from the state of Odisha, and I can see some of the ICMR Institute scientists and some of the faculty members from the medical colleges. I think I'm very happy to see that many of the people you have joined here. But I think I really need a feedback from all of you, the way it has been prepared. So as it has been explained very well by the chairperson, Professor Khaitan, who was chairing the group of dermatology. And similarly, we have 23 specialities. So we have the chairpersons from all the specialities, and this activity is going to be continued in future as well. But we want to move forward in this direction with all of your suggestions and how it will be utility for you, all of you, to be at a field level. So today, whosoever has joined in this webinar, I request you to go to the website. It has been shared with you in your chat box. Download the application and send it to as many physicians as possible. And I think what Dr. Deepika has already mentioned, that we really need to get these conditions diagnosed at a primary healthcare level. They should not be, reaching at a tertiary healthcare level. We all are physicians, so we all are, trained into that system that, they have to be treated at where it is mostly accessible. We don't want patients to move here and there from one facility to another facility. So with that intention, and it can be a resource, saver as well. It takes their, daily wages. It takes a lot of money for them to get the investigations done and all that. So if these STWs are really followed up at a peripheral level, I think I am of the opinion, and experts would also be of the opinion, that of course, large number of patients can be benefited through these STWs. So again, I would like to invite certain comments from you, and if not now, you can share those comments to the email ID which has been shared into your chat box. So,
Dr. Ashu, there's a question for you from somebody. How to get the hard copy for use in the hospital? What is the price, and can it be booked online? They want the hard copy.
I think thank you for raising, queries and, need for getting the hardbound copies as well. By now, I think it's a area, time for the online and all those kind of things. We are trying to make it more friendly, user friendly, to be make it available on the website and then. But these are the hard copies. We don't have only this volume, we have other volumes as well. So this is the third volume and dermatology is in this volume. I think if we get more requests, we can get it printed, we can send it to the hospitals. But right now, I mean, we don't have much copies to be distributed to all the states. But I think if the states demand it, it has to be come in bulk so that we can get it printed and send it to the states.
In fact, maybe we will discuss with Dr. Sudha also. Because
Yes.
So because hard copy will require a little more extra.
Yeah, it will be more resource.
Yeah.
We'll just respond to a few comments. I think somebody wrote about leprosy. So like we mentioned, we have not covered all. But leprosy has been mentioned in vitiligo, the differential diagnosis. And we wanted, because that's the most common error that people make, that they refer patients of vitiligo as leprosy. And the second thing I think is by
no, so the national program, Dr. Deepika.
Right.
So those which are part of national programs like leprosy and STI, we have not covered in STW because the national programs are anyway well planned and well designed.
Yeah, but we have added it in the differential diagnosis of vitiligo. And that is also the reason, because we have this syndromic management, that we have not covered STI. Like Dr. Khaitan mentioned, we were given 10 disorders. We anyway stretched it to 13. And we hope with the support of ICMR to add more. Then I think there was one comment about drug provocation test. Is it advisable at the primary level? I think Dr. Khaitan mentioned that it is only recommended as inpatient at tertiary level. So if it is to be undertaken, it is by tertiary care or a specialist. So a specialist can undertake up, but we are not recommending at the primary level. That has been mentioned. Well, if we missed any question, I don't know. We missed any.
I could see our President-elect, Dr. Manjunath Shenoy.
Okay.
If he has any particular comment, Dr. Grewal is
Dr.
there.
Grewal has already commented. If he has any other comment. Can't hear you, sir.
Please unmute. Please unmute.
So firstly, compliments Dr. Binod and Dr. Deepika. Great initiative, very well articulated, and I think it would go down as a landmark achievement in dermatology's service to the community, particularly in the realm of the nebulous abstract treatment that is offered in the primary care domain, and where we all aware of its consequences. Having said that, I would say that, certain don'ts need to be do's and don'ts. The don'ts need to be emphasized about where people should not trespass. That's just a suggestion. I think overall the content, its articulation, and the sort of ease of navigation of information is very praiseworthy. Compliments once again, very well appreciated.
Thank you, sir.
Thank you, sir.
Thank you. And thank you, Dr. Ashu, for the initiative.
Is it possible? Can I speak?
Yes, sir.
Yes.
Dr. Jay,
Yeah.
Dr. Jaydev here.
Yeah, Dr. Betkaru, yes.
Yeah, can all these things can be planned, these webinars, like schedule can be put up so that, dermatology and other subjects, various, this STW schedules, if you can, webinars can be scheduled over a period of so many months, covering all the dermatological diseases, and apart from that, the others also.
So, sir, that's a very good suggestion. As Dr. Ashu will say, there is some move to do that, but I think she'll be able to answer that better.
Yeah, I think, thank you, Dr. Vijay, for that, comment and suggestion. I think this is the first, and we will continue having the series of webinars, maybe not only from dermatology. As I said, we have 23 specialities. We will cover each specialty one by one. And I think today, apart from dermatologists, many other physicians also have joined from, not non-dermatologists also, and maybe utility to them. But I think this webinar series will continue. We will put the schedule and calendar of the webinar on our ICMR website and on the social media as and when it is made available. And I think we will make an annual calendar. I'll discuss with my team. And if we adhere to that schedule, then it will be displayed, sir. Thank you for the suggestion.
That is a good one, so that we can our people can attend, even dermatologists, or we can attend the other subjects also.
I would request all that, because the main thing is if the community medicine people take it to the community, I think that is the best way that we can, like I said, the syndromic management succeeded because it was multidisciplinary. So only then we can actually make a change and have the dermatological effective management at the grassroots level.
Yeah, so maybe Dr. Ashu, you are from that background. So a communication with all the PSM departments may be of wider dissemination.
Yeah, I think again, thanks for that suggestion. I mean, I'm already in contact with the associations as well. I think the specialty association also I'm in contact. I think the dermatologists can take care of the derma STWs. But otherwise, we are planning, I'm already spoken to Indian Public Health Association and Indian Association of Preventive and Social Medicine. And I've already, attended few conferences where there is a, participation of these experts are there. So the efforts now are being taken, less of the development of the newer STWs and wider dissemination of those who are already with us. So that has been the plan by right now. And we will be, maybe I think with every state, we were planning to have an operational component of its implementation. So it is just a dissemination part. And once we go for implementation, then only its usual, its actual utility will come into and move. So anybody who is coming with the condition of scabies or coming with the condition of alopecia or any other condition, and if they found that, okay, I need to consult an STW, then only I will think that the whole exercise of sitting in this room and developing the workflow is beneficial. So they have to be put in use as much as possible. And please give us a chance to improve upon it and improve the content and whatever the way the physician, the dermatologist want us to put it into the content part. So that's more important, sir. So we are in, doing that exercise to reach out to as maximum as possible.
So there is another query that is for Dr. Lokesh, whether he will provide a recording of this.
We will upload it our STW website as well as ICMR YouTube channel.
Okay. So they have an ICMR YouTube channel and they are also requesting for the link of all the STWs. You can put it in the chat box.
Or you can show the website. They can, or you can put the link. So link we are putting it on the chat box. And all the specialties, not only dermatology, volume 1, cardiology, endocrinology, nephrology, ENT, ophthalmology, orthopedics. So all these specialties are available. Whatever STW you want to see, you can download, you can see, and not only see, as a physician, I will request that try to put it into practice. If in practice, if they feel some kind of challenges that this is not mentioned, so probably please communicate to us so that in the another corrigendum or any revised revision version we can put up. Or if there is any new literature which has come up which has not been included into the STW. So you will find at the end of every STW we have put up references, and at the upper corner of the STW we have put up the year. So the dermatology STWs have been put up in the month of July 2022. July 2022. If any evidence, any new literature, any new drug has come up after that, which may have not been, noticed by us. So please communicate to us so we can incorporate that into the STW.
Thank you, Dr. Ashul. And like we mentioned, this will undergo revision because it's dynamic. It cannot be static. So there will be, it will be updated as the more information comes in or the drug sensitivity or any other recommendation changes over time.
And at the end, I must thank ICMR.
Yes.
Last 3 years, I mean, it was not easy to make. When we were told that make 1 page of one topic, we thought it is very simple. But we realized that it is not that simple, but then make it comprehensive and handy also, not only all the information, but easy to comprehend information. So we are thankful to ICMR for that.
Right, because everybody felt very passionately about each point. So to include, ultimately every point included has undergone a lot of discussion.
Yes. Yeah, a lot of deliberations have gone in, so. Yeah. So thank you, all the participants, those who have joined today with us, with a request to further disseminate it to at least minimum 50 more your contacts. So that is how it will spread across the country. And we will continue having the webinars and in the next month also, and we will put that calendar of those webinars well in advance on our website and to the social media and to the STW website. Queries from, can we have it from the secretary? Yes, secretary STWs are available on the volume. We will plan the webinars on each and every subject in the future. Thank you, everyone. Thanks for participating.
Thank you.
Thank you.
And